Welcome. Good morning from Vietnam. And welcome all of you to 14th Congress of Asci 2021. Our sixth topic today is Space Focus, Artificial Intelligence. And I am Dr. Liu from Vietnam, and co-chair with me, Professor Sang Choi from Korea. Please, Professor Sang Choi, some words, please.
Good afternoon, everyone. I'm Dr. Sang Choi from Seoul National University, Bundang Hospital.
So, our session we have for speaker, first speaker from Dr. Joseph Sok, the second Professor Michael Sanino, and the third Professor Roberto Lang, and the last Professor Sang Choi. So now I'd like to introduce Professor Sang Choi to introduce the first speaker, please.
Doctor, you first.
I'd like to introduce Professor Joseph Sok, and he is a professor in radiology, cardiovascular medicine and pediatrics, and he is director of the Division of Cardiovascular Imaging and vice chair of research at the Medical University of South Carolina in Charleston. And he is past president of the North American Society for Cardiovascular Imaging, and is member of numerous other scientific societies. And he is international speaker with more than 400 invited lecture and published more than 500 articles in scientific research and many books also. Please, Professor Joseph Sok.
Hello, everybody. Thanks for tuning in. I'm Joe Shep from the Medical University of South Carolina in the United States. I'm truly honored to speak at this prestigious conference, but believe me, I would much rather mingle with you in person in beautiful Vietnam and Da Nang. I hope we can do that in the not so distant future. Now let's examine together artificial intelligence applications in cardiac CT. Here are my disclosures. I have financial ties to the companies that you see listed here. As you all know, radiologists around the world get a lot busier. So the number of CT scans and MRI scans is just skyrocketing, and there's a substantial shortage of radiologists throughout the world. Fortunately, the machines are getting smarter. Here you see the development of artificial intelligence performance compared to the human error rate. As you can see, already in the year of 2017, the machines were partially smarter than the human observers. So that's good news, I think, considering our workloads. Artificial intelligence in cardiac imaging has huge potential in a number of different scenarios. For vascular segmentation and labeling to streamline things, for coronary calcium scoring, for planimetric assessment, valve measurements, fractional flow reserve based on coronary CTA, coronary artery disease assessment, radionomics prognosis, and lastly, the creation of digital twins. We're going to talk about all these topics. Now let's start with the measurement aspect. We all know how difficult it is to correctly measure the dimensions of an aorta, but that's very important, obviously, in our daily life to see whether an aortic aneurysm is about to rupture. If you want to do it right, you have to do it in the three-dimensional space at all the levels that the American Heart Association recommends. Now we have computers that can do exactly that for us. So that takes out a lot of the tedious radiologist's work to perform those 3D measurements on all those levels. That's thanks to artificial intelligence. We have experience with one of those algorithms that automatically does that. This is the output of the actual platform that you can see here. Compared that with actual human measurements, and what you can see is that we're right on the money or better, the computer is right on the money. So artificial intelligence performs extremely well compared to tedious manual human measurements. So that facilitates workflows. We're teaching computers increasingly to measure stenosis for us and to do things around the coronary arteries, but for that, the computer first has to learn what a coronary artery looks like. It has to learn how to track it. This is another prototype that we have been working with that does exactly that. So it segments out the coronary artery tree, even kind of to the smallest side branches, and it does that extremely well. So that's the prerequisite, I think, for all coronary work going forward. The training data set, 99% accuracy was achieved, which is, I think, remarkable. On the test set, 92% accuracy in labeling the coronary artery tree. So we're making great progress. Coronary artery calcium scoring is known as a powerful risk marker and oftentimes a tiebreaker when you try to decide what needs to happen next with a patient. But we all know how tedious it is to kind of manually mark every calcified lesion in the coronary artery tree. It's really not work worthy of a physician. Again, like computers come to the rescue. We've been working with a prototype where the computer automatically rips out the calcifications from the dataset. It gives us a visual, as you can see here on the left, where we find the coronary artery calcifications. But more importantly, it automatically quantifies it for us. And we again put that to the test. So we looked at the accuracy of quantification, and you basically see that the computer and the human observer measure exactly the same. So there is no difference and there is no misclassification in risk categories. So computers help us greatly to save time and get away from mundane manual work. We can take that stuff one step further. This is an interesting article that looked at a similar approach to extract coronary artery calcium data from chest CTs from various different cohorts. And if you look at that, the artificial intelligence algorithm was able to automatically calculate that from non-gated chest CTs and then obviously predict risk for adverse cardiac events from that, just based on regular chest CT studies. And without the tedious work that would be required to extract calcium scores from a chest CT, which is even more difficult than from a regular calcium scoring study. So basically, a very comprehensive, holistic approach to imaging and risk stratification. We're doing a whole lot of mitral valve work as of late, and the planning, as you know, of mitral valve work in structural heart disease therapy is very, very difficult because of the unusual anatomy of the mitral valve. A computer has it much easier to actually go into that three-dimensional or four-dimensional space and come up with the exact plane measurements that would be very difficult for a human observer to extract manually. But the computer obviously has no problem with that, seeing in three-dimensional, four-dimensional space. So that's going to become more and more important in structural heart disease treatment. And again, the computers perform extremely well if you look at the performance numbers here. Now, everybody is familiar with CT fractional flow reserve derivation that can be done with convolutional fluid dynamics, but we can also use artificial intelligence for that purpose. It provides us partially with spectacular visuals. Just look at this here, where the AI-generated FFRCT map is superimposed on a cinematic rendering of the heart of a patient. So this is great for communication. We can tell the patient exactly where the problem is. We can communicate with our referring physicians exactly where the problem is. Now, AI-based CT-FFR is based on some training data sets that the computers learned from to understand what a coronary artery stenosis looks like. But then the computers started training themselves by generating synthetic data sets to just increase their knowledge base. And that correlates extremely well with invasive pre-measured FFR. There are many players out there who use artificial intelligence. This is just another example that's also based on artificial intelligence to derive fractional flow reserve from coronary artery CT data. This is yet another algorithm that we have also experience with in our lab, where we basically used the machine learning algorithm to assess the fractional flow reserve, and it came out right on the money with 0.76 and an FFR that was invasively measured with 0.75 for this equivocal proximal LAD stenosis here. We put this particular machine learning algorithm to the test in a large global consortium from countries in Asia, Europe, and in the United States, where we tested as a consortium that machine learning AI algorithm for FFRCT derivation. This was the original article where we basically tested the area under the curve that can be achieved when coronary artery CTA analysis is combined with machine learning FFRCT. And as in all these applications is true, you can see that obviously combining FFRCT with CTA is much more precise, much more specific for accurate lesion detection, for accurate detection of lesions that matter and produce lesion-specific ischemia. So very, very helpful. We also compared that with the traditional method with computational fluid dynamics, and we found that there is actually no difference. So machine learning may be a little bit better than computational fluid dynamics, but it's performing very, very well. Now, it was observed previously that the machine learning algorithms, or that FFRCT per se, is not as sensitive to the Achilles heel of coronary CTA, that is calcium. It was shown in the past that computational fluid dynamics, for instance, is not as much influenced by calcifications than the human observer. And we saw that the same is true with machine learning-based CTFR algorithms. So regardless of the quantity of coronary artery calcium that you see here, the performance numbers don't really go down as much as you would expect from a human observer. Again, that's excellent news, I would think. Now, as always, you want to kick it up a notch. We're taking CTFFR, which is typically used in patients with chronic stable angina, into the acute setting. We looked at the performance of CTFFR in the emergency room setting in patients who presented with acute chest pain. And we found that the performance really is really not worse than in the chronic setting. So this is well suited, especially with shorter and shorter computation times, to be taken into the emergency arena. What's beyond FFR in the heart? Well, there's a lot artificial intelligence and machine learning have to offer. We know for quite some time that computers are actually better than humans and their risk factor predictions to figure out which patient will have an adverse outcome. So if you combine computer power with and feed them all the features that can be found in a coronary CTA dataset regarding stenosis and regarding plaque composition, and combine that with the medical record, you have an extremely powerful tool of risk prediction, much better than anything that the traditional risk scores could actually deliver. So we've known that. How can we make it better? Well, we can take away the tedious work of human plaque analysis. So, and we have interesting experience with a prototype that does exactly that. So it automatically segments the coronary artery tree based on the methods that we talked about initially. and then finds the plaque and quantifies them and analyzes them. So again, workflow facilitation. This is kind of the integration of those principles into a semi-finished product. We're going to present that at this year's RSNA. We have very good visuals of the anti-atherosclerotic plaque burden, and we have excellent sensitivity and specificity of the algorithm to detect stenosis and to measure stenosis. So we're making great progress there. Specificity could probably still be improved, but remember this is a very early work and it's going to significantly improve over the next few years. Coronary CT is also an excellent playing field for radiomics. Radiomics obviously is having the computer look at things and basically find connections and patterns and relationships in data that a human mind normally would not think of. And kind of the pixel and voxel structure, the grayscale structure of a coronary CT angiogram and of coronary artery plaque imaging is ideally suited to have a computer a go at it to find connections between the pattern of plaque, the pattern of the overall coronary artery tree, and patient outcome. This is an example where this was done in an ex vivo setting, where these are superimposed CT images with histopathologic sections here. And an AI algorithm was trained that was excellent in its performance to detect advanced coronary plaque based on the grayscale patterns that you find in your coronary CT image. So if you take that to the human scale, I think that will be extremely helpful going forward. AI can also help us elucidate mechanisms of pathology. This is a very interesting study that looked at different pathways of cardiovascular disease evolution in serial scans. It finds that cocaine use, for instance, HIV infection, and atherosclerotic disease, they all result in coronary artery plaques, but the radiomics features point in the direction that they all have a different pathway of progression, different triggers really that make them progress. And I think that's obviously a great possibility to influence treatment. Lastly, what we're currently working on is creating digital heart twins, which is basically taking all the data that we have on a patient, imaging data, EKGs, the medical record, and basically put them all into an avatar of a patient's heart. A great training tool, obviously, so you can poison the heart and it stops, and you can reanimate it. That's very good for students to learn. But more importantly, you have kind of a digital library of what a patient heart looks like and may change over time. And you may use that for risk prediction, treatment strategies, and therapeutic management. So I expect that many other organ systems will be benefit from different approaches, although as always, I think the heart is going to be the most complex. So in summary, we have great opportunities for AI and cardiac imaging. It's efficient, it helps us with our quantification, takes away those tedious tasks that tear us down. There is great opportunity, I think, in determining patient management by using FFRCT based on machine learning. Radiomics is poised to give us better insights into pathophysiology and prognosis, and we can simulate therapy and decide best courses of patient management with our digital twins. With that, I thank you kindly, and again, I wish I could be with you. See you soon. Stay safe. Take care.
Thank you very much for excellent presentation of Professor Joseph Sok. And if you have any question, please send the question to Q&A. Then we have a question discussion at the end of the session. And as we move to the next speaker, I'd like to introduce Professor Michael Cello. He's an Associate Professor of Medicine, Radiology, and Biomedical Engineering. And he's the writer of the Cardiac Mri, and he is also the medical director of the echocardiography at the University of Virginia. Please, Professor Michael Cello.
Okay, thank you very much, and it's an honor to be here. I'm going to talk about AI applications in cardiac MRI. Here are my disclosures. And so AI in cardiovascular imaging is growing at an exponential rate, with about 20% of the volume being in cardiovascular imaging, which is really why this kind of session is very important at this time. So when we talk about cardiac MRI, there's a number of applications along the spectrum, from determining appropriate indications and patient scheduling, acquiring data on the scanner, reconstructing images and determining image quality, using segmentation, quantification, and radiomics to analyze our images, classification and reporting to do automatic diagnosis and reporting, and finally, assessing prognosis. So I'm going to show a case here, a 46-year-old female, past medical history of mitral valve prolapse that was diagnosed a few years ago. She had an echo that looked like moderate MR, but her cardiologist thought that her murmur and symptoms suggested severe MR, and she was referred for a cardiac MRI. And so here are her MRI images, and we can see she's got mitral annular disjunction with a posteriorly directed jet, and a leak here along the A2P to AP A3P3 junction. So in order to quantify mitral regurgitation by cardiac MRI, we need to contour the whole left ventricle in order to determine the stroke volume. And then we need to use flow measurements to determine the forward stroke volume. And the difference for that is the regurgitant fraction. So previously we would do all of this by hand, but now with artificial intelligence segmentation techniques, we bring up a set here of short axis images covering the heart. And then here in about less than a minute, the computer will automatically segment the entire heart throughout the cardiac cycle, something that probably would have taken us on the order of 5 minutes just to do end systole and end diastole. And then once we have this segmentation here, then we move on to doing the flow measurement across the aorta. And again, using machine learning segmentation, this can be segmented very rapidly. And really in under a minute, we're able to quantify mitral regurgitation. So in this particular case, we have the segmentation from deep learning, the segmentation of the flow from deep learning, enabling us to rapidly quantify the regurgitant volume and regurgitant fraction, in this case corresponding to moderate MR. So where are places that AI could play a role? Bob Balaban, who's the head of the NHLBI, gave a talk at SCMR basically saying that as cardiologists, we really needed to stop drawing circles. And really in the last couple of years with AI, this has really been a major change. So what are things that we're able to do? We can assess image quality, identify different types of cardiac MRI images, automatically arrange studies, identify and segment structures in CMR imaging, and perform post-processing. Within the range of clinical decision support, we can automatically generate structured reports, help automatically determine cardiac pathology, detect anomalies and predict outcomes. And finally, AI can be used to drive the MR scanner. So why might we need to assess image quality? If we were just taking a lot of data from a PACS system and we wanted to make sure that the images that we were training data on were good, we'd want to be able to throw out cases like this where there's clear motion artifact. And this can be done using CNN approaches, where it's been shown that you can detect mistriggering, breathing, and arrhythmia artifacts using a number of different techniques in order to make sure you have high quality images. A second thing that's typically needed to do is to find the left ventricle and draw a bounding box. Again, this is a very easy thing to do with a CNN-based approach, and this can be done with very high accuracy in order to detect the left ventricle, which may be needed for future post-processing, such as radiomic analysis. Networks can be used to identify the type of image. This can be useful for automatically arranging studies. And this is really something that can be thought of as a multi-categorical classification problem, which has been solved in a lot of areas within AI. The biggest thing I think in terms of clinical impact right now has really been automatic segmentation. Most of these techniques are based on some type of UNet or encoder-decoder network. And when these are tested as compared to humans, there's very small bias in measuring left ventricular ejection fraction and volumes. There's a number of different CNN approaches. Here's a fully connected CNN based on the UK Biobank, demonstrating very high accuracy compared to consensus segmentation. And here's showing segmentation of the left ventricle, the wall, the cavity, the right ventricle, and then the atria. So we can also use AI to automatically arrange our images, say to pick out all the functional images, to pick out the late gadolinium enhancement images, to automatically arrange the studies so that we can rapidly look at function and delayed enhancement. And then within the same types of platforms, we can automatically perform the segmentation and quantification. This has now been done over multiple vendors. Here's work from Metis, as well as from Circle, showing complete heart segmentation. And this has made a huge impact in cardiac MR. So the segmentation techniques can really extend across different modalities, imaging heart function with cine, perfusion, late gadolinium enhancement. Again, most of these based on some type of UNet type architecture. Segmentation has also been applied to localize scar within late gadolinium enhancement images, to do segmentation of T1 maps, and to segment myocardial quantitative perfusion images. So another very active area is in image reconstruction. Here's a technique for radial images where data is acquired along radial trajectories instead of along a regular Cartesian trajectory. So these reconstructions tend to take a very long time, and these AI techniques can reduce the reconstruction time by about 14-fold. It's also been applied to simultaneous multi-slice imaging where multiple slices are excited at the same time. Here's the deep learning reconstruction as compared to the ground truth. Again, about 200-fold improvement in reconstruction time. We've been working with a certain type of spiral images from myocardial perfusion imaging using deep learning reconstructions, and we've really reduced the reconstruction time for a slice from about 40 minutes to about 700 milliseconds. Some very cool work presented in the last year in scientific reports is really extending this to 3D using 4D convolutional networks. Here, using a Casper type acquisition strategy, they're able to get whole heart coverage in a free breathing acquisition. And this has now become clinically available. Here's an example from GE with their technique called Air Recon, where the conventional images, we can see that they're noisy. When you apply this deep learning reconstruction, you can see there's significant denoising of the images. AI can also be used for image registration, which is a challenge in a lot of MR applications, such as when we want to quantify things through temporal series, such as in dynamic images. And here we're using AI to drive our registration technique so that we can perform parametric maps of perfusion. AI has also been used for localization, such as localizing the heart cavity for quantitative perfusion imaging in order to quantify different parameters related to perfusion. And models have been, complete pipelines have been created, which include bounding box of the heart, segmenting the myocardium, and then also doing the tracer kinetic modeling using deep learning. And some very nice work from the King's College group showing that predicted images that are very similar to the ground truth reconstructions. This work can also be applied for T1 mapping, where the deep learning networks can be used for both the reconstruction as well as the post-processing, demonstrating a reduction in noise as compared to the standard techniques. So the other area I want to talk about in the second half is clinical decision support. So this is really providing clinicians with knowledge and person-specific information presented at the appropriate time to enhance healthcare delivery. And in this, we really think about how do we use this for assessing diagnosis, prognosis, providing other information at the time of analyzing the images, which is clinically important. So what are some deep learning targets in this area? Predicting obstructive coronary disease from CMR stress imaging, predicting scar by late gadolinium enhancement using non-contrast techniques, thinking about response to CRT, and predicting a need for ICD. So there's nice work done in this last year based on the, from Oxford, based on the hypertrophic cardiomyopathy registry. And they took pre-contrast cine images, inversion recovery weighted images, and T1 maps, and they fed it into a network, and they produced an image which they call virtual native enhancement, which is essentially a delayed enhancement appearing image acquired from pre-contrast images. And so this is very interesting work here showing that the concordance between late gadolinium enhancement, a technique that needs gadolinium contrast, and this VNE, which is really based on native T1 mapping combined with the anatomic images from cine. AI can also be used for disease classification. This is work from the National Institutes of Health, where they completely generate inline quantitative perfusion maps, perform bullseye parameters, and then they're able to use this to classify coronary artery disease with high accuracy. So how about looking at prognosis? There's interest in predicting adverse cardiovascular events, predicting risk of future arrhythmias, and predicting worsening heart failure. This is a little bit less developed than it has been in some of the things that Dr. Sheff showed in the last talk. So when we think about automatic detection of pathology, this is ultimately, again, a multi-level classification problem, albeit much harder than determining the type of image. But we can imagine in the future being able to have these networks potentially give us either a differential diagnosis based on the scar pattern or potentially directly providing the diagnosis. Often when we're reading MR or CT, it'd be nice to have something looking for extracardiac anomalies to make sure that we're not missing these when we're focused on the heart. And this has really been come to fruition in the CT world, sort of newer in the MR arena. And then now that we're able to generate a whole bunch of quantitative data, the next step is really to use that data to drive our automatic reporting, potentially combined with natural language processing to give more coherent structure to our reports. So I kind of want to end with another case. This is a little bit of a futuristic case, but we can imagine a 43-year-old male, non-Hodgkin's lymphoma, undergoing anthracycline therapy. His echo showed a borderline EF. He needed to have an MR, but was unable to perform breath holding, and he was sent for a cardiac MRI for evaluation of LV function. So this is some work by Heart Vista, which is a startup out of Stanford, where they automatically are using AI to drive the scanner to automatically do the scan plane analysis. So here, automatically detecting a 2-chamber view, and then moving to be able to detect a short axis view without any user interaction, all driven by AI. So now over about a 3-minute scan, they're able to acquire Cine images and 4-chamber short axis images, 3-chamber, four-chamber free breathing. And then right in line, there's going to be automatic quantification of the function after getting the Cine images. So instead of thinking about our typical study that we may do in oncology, in about 3 minutes, we could go from putting a patient in a scanner, completely real time and free breathing, be able to quantify their LV function. So there's a lot of work in this area of automatic view planning, typically based on reinforcement learning or based on landmark techniques in order to pick out landmarks in order to define the other cardiac planes. So just as a summary of where I think things are for workflow automation, this is a work in progress and coming soon, but I think we'll see more for automatically scheduling and protocol in studies. Automated scanning is becoming available, this kind of idea of push button MRI. Image reconstruction is a work in progress for some applications, but is now becoming clinically available by at least 2 of the major MRI vendors. Image segmentation across Cine, late gadolinium enhancement, perfusion, flow, and T1 mapping is now really relatively widely available by a number of post-processing vendors, along with automatic quantification. There's growing interest in doing the automatic reporting and predicting diagnosis and prognosis, but these are still really more works in progress in the MR field at this time. So to end with a couple of key points, AI and deep learning are revolutionizing cardiac MRI. There's a number of applications that are already clinically available. These include segmentation, reconstruction, and quantification. And newer applications are continuing to be developed, including workflow, automation, autonomous scanning, reporting, and automatic diagnosis. So to summarize, AI has multiple applications in cardiac MR visualization, clinical decision support, as well as driving the scanner. It's well established for both identifying and segmenting LV structures, and this has really revolutionized our post-processing and cardiac MRI over the last few years. There's applications for clinical decision support, but this is not as well established, and I think this will really be an important area over the next couple of years. And finally, this is really an area where it's important to have collaboration between clinicians, both cardiologists, radiologists, and engineers, to really develop systems that are robust, as well as have clear failure modes, so we know when these things didn't work properly. So again, it's really an honor to be here and present this talk. Thank you very much for the invitation.
Thank you very much for excellent presentation concerning about the AI application in cardiac MR. Please stay with us at the end of the session for discussion. Now I move to Professor Sang Choi to introduce the next speaker, please.
Thank you. So let's move on. Next topic. Next topic is AI application in cardiography. So presented by Roberto Lang. So Professor Lang is from University of Chicago, and he is director of cardiac imaging and professor of medicine and biology in University of Chicago. And he was past president of American Society of Cardiography, and currently serves as vice president of MBE. Okay. Professor Lang, please.
Well, hello, everybody. It is the greatest of pleasures to provide my talk today on the artificial intelligence applications in echocardiography. I think it's pertinent that we first start by describing what is artificial intelligence. And I always like to come up with this sentence by Albert Einstein, who said that computers are incredibly fast, accurate, and stupid, while human beings are incredibly slow, inaccurate, but brilliant. And together, they are powerful beyond any imagination. When we think about artificial intelligence, we are enabling computers to think. And within artificial intelligence, you're going to learn that many of the programs in echocardiography use machine learning, in which we create rules for computers to learn supervised from data. Then we have deep learning, which is a subset of machine learning, in which computer networks which are capable of learning from unsupervised with regard to data. And then we have big data, in which we truly understand data. And big data, of course, uses probability, statistics, algebra, and a lot of other programming. Now, 85% of people in the United States use every day at least one program or service that uses certain features of artificial intelligence. So let's briefly talk about how AI works. So let's assume that we want to think of a setting of supervised learning in which we are trying to teach a computer to differentiate a cat from a dog, from a bird. So we have initially training data, and we train the computer by teaching them all about relevant anatomic features that each of these animals have, like the beak or the thin legs of a bird. Once we have trained the computer with multiple data sets, the computer is now able to learn or to separate which are and make an accurate prediction of a cat, a dog, or a bird. So we initially have this, which is called the testing data, to do later a prediction, all in a supervised version. When we think about unsupervised, we're thinking usually about deep learning. And I always think about, here you see my grandchildren, and how do we teach children what a penguin is? You know, we initially show them a picture in a book or a movie or a stuffed animal or a photograph. And all of this information goes into the convolutional neural network of these kids. And one day they are capable to, in an unsupervised way, to make a diagnosis that is a penguin. That brings us to the fact that when we train a computer, if we put a lot of data into a computer, which is really bad data, you're not going to get a jewel out on the other side. It's sort of most probably that if the data that you're training a computer is not good, you're going to get a garbage out. So I think it's sort of very important to understand that the training data sets need to be very good. So let's talk a little bit about how in imaging all these artificial intelligence methodologies have been used. And to date, most of the methodologies are the ologies, which I like to call, like most of AI has been applied to radiology, dermatology, ophthalmology, and pathology. All of these have in common that the images are actually stationary, and that makes things very difficult, but they're very easy or easier. So you can see here that there are already studies in which a computer that is pre-trained is capable of automatically diagnosis, for example, a tumor, and is more accurate. A computer is more accurate than a radiologist to make this type of diagnosis. This is a study that was done at Stanford University. Now, echocardiography is much more difficult. Echocardiographic images, as you all know, can be obtained from different positions. We have multiple views. In each of these images, there are multiple levels of gray and multiple colors. It is not surprising that echocardiography has long suffered from problems of inconsistency and inter and intra-observer variability. So when we talk about AI in medical ultrasound, there are many parts that we need to tackle in this diagnostic chain: image acquisition, image analysis, review, report findings, and the mining of the data. Most of the work has been done with machine learning, and I'm going to show you a little bit about image classification, automated measurements, and automated findings. It is possible, this is a movie of James Bond, in which a computer has been taught to identify every piece of information that you see in this movie: a window, an umbrella, a person, a chair, etc., etc. So if this can be done, it is of course easy for us to teach a computer all the different echocardiographic views that we have, 17 of these, and show them all, and teach a computer, train a computer in which you show particular anatomical features for a computer to identify the different types of echocardiographic views. And we completed a study in which we trained a computer with around 250,000 images. And you can see that when you have the ground truth by a human versus a machine learning labels, we can see that the computer is capable of identifying all of these views in approximately 80 to 98% of the time. So it's a very accurate. Now, if you have a computer that is capable, we can identify the different views, you can start thinking about this concept of reading in stacks. Reading in stacks means, you know, when we read an echocardiogram nowadays, like you all do, we have all of these movies, about 60 of them, we acquire them, and then we have to try to remember what we saw and integrate this information. Now, if a computer is capable of identifying it, we can say this is a patient with prolapse, and what we can tell a computer then is, show me all of the views in which I can see the mitral valve. And this, of course, allows me to make an interpretation of in stacks. You can do the mitral valve, then I could tell the computer, now show me, for example, all the images in which I see the left ventricle with color or without color, or show me all the images in which I need to make a diagnosis of a diastolic dysfunction. So once we do that, if we can identify these views and we can stack them in groups, we can teach a computer how to make all of the different types of measurements that we need. And this is a little bit what we have been working lately. This is just to show you that all of these measurements on this list here on the right can be made automatically by a computer once the computer recognizes which view is the one that you are seeing. And here is an example in which we are using machine learning. You can see how a computer very quickly makes the diagnosis of the volumes that then a human can change. And you can see all the measurements on the side. Here, for example, I want to do the left atrial measurement. I need to just click on that image, and all of these measurements are being done. In this particular case, I'm now starting to teach a computer how to do this machine learning based measurements of in this case, longitudinal strain. Now, a computer, and we have shown this very clearly, we and others, a computer is capable of making these accurate measurements based on guidelines with a lot of precision. Not only you can do it with precision, but compared to different types of intra and inter-observer variability, the variability of a computer to make these measurements is much less. So it works sort of very carefully. And this is another example of a work we did in which all of this machine learning was used to make quantitative measurements in 3D of left atrial chamber volumes. And this is an example of a cut frame of a 3D in which, using machine learning, we are doing volumetric measurements of the ventricle. And this is a little bit, again, the idea. You take this chunk of LV volume, you take a library of thousands of cases, you teach a computer then creates a generic model of all of the chambers of the heart that then needs to adapt itself locally and try and take care of the variations in dropout, acoustic clutter, and ventricular shape data set orientation. So this, of course, leads then to this fully automated 3D chamber quantitation based on machine learning, in which we can get the instantaneous changes of left ventricular volume and left atrial volume versus time. This, of course, then can be applied, as you can see here, to the right ventricle and the right atrium at the same time. This, of course, use of machine learning decreases the amount of time that you require to interpret an echocardiogram. And you can see that in order to do all the measurements that you need to do in 2D on 50 echoes in a day, it would take you around 3 hours. And you can see that when you do this machine learning with border correction by a human, you can actually bring this time to about only 1 hour. So when you think about an echocardiogram, you see that today we select a view, we do a measurement, we perform it, we verify the contours, we review the results, and we report the findings. Now, these 3 portions can all be done with machine learning, artificial intelligence. We still need to verify the contours, review the results, but the report findings can also be done with automated intelligence. Other colleagues have used artificial intelligence to, for example, differentiate constrictive pericarditis from restrictive cardiomyopathy. There are now studies also that allow the use of artificial intelligence to detect or separate hypertrophic cardiomyopathy from amyloidosis and from pulmonary arterial hypertension. And interestingly, a study in which using AI, it is possible to make a discrimination between hypertrophic cardiomyopathy and an athlete's heart. So the applications are growing. And now let me show you a little bit now towards the end of my talk to show you about the fact that in addition to the interpretation and quantification, there is a whole set of work that is being done now to use to use artificial intelligence to guide image acquisition, similar to what you do with the GPS of a car. And this is a study that we did in which we described the utility of a deep learning algorithm to guide people that never used echocardiography to acquire echocardiograms for limited diagnostic use. And this is an example by one of these companies in which they trained a computer by doing over 5 million probe manipulations, and then to have a computer guide you towards the assessment. This is another example of a different company. You see that you take the transducer, you put it, and now the computer is guiding you to get to the center point. You want to go to the center point of that target, and once you get there, you can see it now tells you to rotate it, and once you're overimposed, you know that you have the apical 4-chamber view, and now you can auto-acquire, and you can restart your work. So this is an example now of, let me just advance this. This is an example of an echocardiogram that was done by a nurse who had never experienced the ability to acquire an echocardiogram, and you would understand that these are not perfect views. This is a parasternal long and 2 short axes at the level of the mitral valve, at the level of papillary vessels. Though yet these images are not perfect, they're definitely diagnostic and would allow you to say that an echo is pumping or not pumping, and if they are pericardial effusion. Artificial intelligence have also been used by different types of techniques to improve the quality of an image. So look at the endocardial border of these 2 images that have been enhanced in these point-of-care images by the use of artificial intelligence. We all have suffered from COVID and are still suffering. This is a study from my lab in which we saw that how the amount of transthoracic echoes totally were reduced at the time of COVID. And we were able to actually do a study from different parts of the world in which all of these countries send their COVID-19 echoes of patients to the cloud. And in the cloud, we did, first of all, a standard echo expert read by 3 readers, and then we measured these same echoes totally automatically using artificial intelligence, getting at the end measurements of AI-based left ventricular ejection fraction and longitudinal strain. So these measurements were done and obtained in a standard way or also using AI. And interestingly, what we found when we tried to predict mortality is that when, for example, left ventricular ejection fraction, because of the variability, when manual measurements were done, it was not predictive of mortality. But when left ventricular ejection fraction was measured with AI, it became significant because there is much less variability when measured by a computer. And the same applied to the longitudinal strain. So we concluded in this study that AI-based LV analysis, but not manual measurements, were significant predictors of in-hospital and follow-up mortality. You can understand that for all the studies that we do using echocardiography, if we would do an analysis using AI, that would increase our statistical power to predict outcomes and maybe needing smaller sample sizes. And we don't need to be afraid. This is, again, the robotic society has this RoboCup in which they do a soccer game. And they predicted by the year 2017 that robots would be able to win against humans in soccer. And you can see that this is definitely not the case. There's still many, many years that are needed and now they will all fall, for these models of AI to win against a human. So I think when we think about AI in echocardiography, is this help or a threat for the physician? I am convinced that all of these AI technologies with respect to ultrasound will dramatically improve the physician's workflow. By using AI and specifically deep learning to assist with image acquisition, measurements, interpretation, all of this will become faster, more reliable, and more consistent. So in order to finish, I would like to tell you that AI will not replace us as echocardiographers, but I am convinced that in the future, echocardiographies who use AI are going to replace echocardiographies that do not use AI. So I think a lot of food for thought, and I would like to thank you very much for your attention.
Thank you, Professor Lang. During this lecture, so we have one question from audience about the previous talk, not this topic. Professor Salerno, can you hear
Yep.
me?
Yep.
Yeah, so question is that how significantly does AI make CMR exam less time consuming in any specific disease? Is there a minute-to-minute study on this? So this is question.
Yeah, I think I think right now the whole field of AI-driven scanning is sort of very new and hasn't really yet been studied in terms of how much faster it's able to make the study. There's a lot of interest in sort of rapid AI-driven scanning with the idea that hopefully a comprehensive scan will be done in under about 15 minutes, and in non-contrast scan maybe on the order of around 5 to 10 minutes. And I think this is going to be an open area that we'll see how much faster AI is able to do this. I think the key things will be is that tasks such as finding the slice locations and scouting, these take time even for an experienced tech, and that can be done very, very fastly with AI. And finally, the post-processing and reporting, I think, is going to improve the workflow from both the acquisition standpoint as well as the analysis of the data.
Okay, thank you very much once again. So any other question or comments from the audience? Okay, let's move to
Can you turn on the mic, Professor Sangeeta, please?
sorry. Okay, thank you very much once again, Dr. Salermo. So let's move on to next topic. Next topic is AI application in nuclear medicine, nuclear cardiology and hybrid imaging. Will be presented by Hong-Yun Choi from Seoul National University Hospital. He is currently an associate professor in Department of Nuclear Medicine in Seoul National University Hospital. Okay, Dr. Choi, please.
Hello, I'm Hong-Yun Choi, a nuclear medicine physician at Seoul National University Hospital. Today, I'm going to talk about AI in nuclear cardiology, focusing on biomarker development beyond diagnosis. Disclaimer, before starting the lecture, I'm a co-founder and CTO of Portray and a scientific advisory board member of AI Nutrition. There are nothing to disclose conflict of potential financial interest regarding this lecture. So today's lecture did not include any products related to these organizations. Okay, as an imaging expert, recent advances in artificial intelligence have changed many many clinical practices, particularly in image reading. So maybe you are already familiar with these situations and related topics. It is not surprising that AI wins human experts in image interpretation, such as skin imaging or some ophthalmological images, or even more recently, deep learning models eventually actively expanded to the pathology images that has very huge image data. And even more, deep learning models can interpret images combined with natural language processing model can generate a sentence describing medical images like radiologist or nuclear medicine physicians or any other imaging expert. So maybe this kind of deep learning models, we can say that these models can be better than us. So, but these kind of models are based on the supervised learning from the specialized data set for diagnostic classification. So, however, the lore of the deep learning model or artificial intelligence is different from the simple diagnostic classification. So we should think that what we done with the functional images or cardiology images for the doctors, and imaging actually could provide more information than a simple diagnostic classification. Let's think about some more clinical situations. This is more important in the functional images for the functional information. The role of functional imaging in diagnosis is not just providing the simple diagnostic classification. Instead, we can get some physiologic or pathologic functional information related to the disease status or prognosis or individual's features. Thus, therefore, the main purpose of the artificial intelligence model for the functional imaging should be different from the diagnostic classification, such as the classification of the malignancy versus benign disorders. However, conventional artificial intelligence models have focused on the accuracy for the diagnostic classification. However, for the cardiology and the functional images, the purpose of artificial intelligence model should be providing the functional information and the personalized functional and physiologic information that can that can characterize the disease and individuals for the prognosis or for the plan for the management. More specifically, this difference is originated from the characteristics of the diagnosis and management of the cardiac disorders. Many disorders, including malignancy, require very simple diagnostic classification or unidimensional information, benign or malignancy, and there are some spectrum. However, for the cardiac disorders, we should consider the multidimensional information for the clinical decision. It includes perfusion or stricture or wall motion or small vessels or FFR. So we should consider this multidimensional information. So the purpose of the artificial intelligence model in the functional images in the cardiology is not just for the accuracy for the diagnosis. However, we should focus on get some valuable quantitative information from the functional cardiology images. Actually, this concept is started from the diagnostic space. When we meet the patients, we get a lot of multidimensional information, including symptoms, signs, and we perform many diagnostic tests, and we can qualitatively define some specific groups, such as high-risk groups for the death and low-risk group for the death. And we define some clinical diagnosis for the patients who require intervention or surgery. But this information are multidimensional information, so these kinds of diagnosis based on the clinical consensus. But the key of the artificial intelligence model is to find the best access to define this kind of disorders. So previous and conventional deep learning and artificial models have focused on the best accuracy for the classify the disease versus normal. However, particularly in the cardiology, the diagnosis is not a clear-cut classification. So we should define some specific axes that integrate the multidimensional information related to the diagnostic test, and we should focus on to find some spectrum of the cardiology disorders. In this regard, I'd like to share some current and futures of the deep learning model for the nuclear cardiology, focusing on this previous concept of the diagnostic space and the purpose of the artificial intelligence model. So as I mentioned before, the main purpose of the artificial intelligence model in the nuclear cardiology is to find some biomarker instead of the simple diagnosis. So some artificial intelligence model application to the nuclear cardiology can successfully suggest some direct biomarker related to the prognosis or some disease status. And actually, the most common nuclear cardiology imaging is myocardial perfusion imaging, and it can provide some conventional, very important information, such as perfusion. So many artificial intelligence models have focused on the new application to get some better quantification using the segmentation or image generation process. So it is related to dose reduction or segmentation, and sometimes generalized models have been used to get better image quality. And finally, I'd like to share some idea of the artificial intelligence model focusing on the data distribution instead of the supervised learning-based clinical label. So the first model is to develop the model that predict the obstructive disease from the SPECT. This model was based on the supervised learning, and this model is very simple model. This model directly used the QPS polar map to predict the prognosis of the patient. This model focused on the risk score instead of simple classification, while this model was trained by supervised learning using the labels of the obstructive stenosis. The model was very simple supervised learning model, but the authors provide some score, quantitative biomarker that reflect the cardiac risk factors instead of the classification. So more specifically, this model was trained by more than 1,000 patients stress myocardial perfusion images on the solid state scanner, and the label for the supervised learning was the 70% narrowing of coronary arteries. So the label was not the prognosis. However, they generate some prognosis score using this label. So the input images was polar maps, and they compare the conventional tissue perfusion deficit images and deep learning-based models. This is the result of the ROC curve, and as you can see in here, the deep learning model shows slightly higher performance than conventional TPD images. And actually, the deep learning models using only the raw image data did not show the better performance than conventional TPD images. However, when the models uses two inputs, raw images and TPD-based polar maps, then the model shows better performance than the conventional analysis. So this group additionally developed another model using the two kinds of images, upright and spine to position SPECT images. Because these two SPECTs can reduce the artifact related to the attenuation correction, so they use this kind of images as an input. And using this kind of images, this shows better performance than conventional TPD but the author suggests that usefulness in the difficult cases. This is an example of the case that shows better performance than the conventional analysis. This model related to the three vessel disease with balanced perfusion defect, and actually this model shows very good results to predict the three vessel disease using the deep learning model. However, this kind of models have some limitations because the performance was just slightly better than the conventional analysis, and the label of this supervised learning was the anatomical stenosis instead of the prognosis. And another problem is explainability, because deep learning based score could not reflect the real perfusion. However, the real importance in the myocardial perfusion imaging is the interpretability of the perfusion itself. Because stenosis causes tissue perfusion and decreased perfusion directly cause tissue death. Therefore, another approach of the AI model is to obtain the conventional measurement, the perfusion value accurately and efficiently. So this is another approach to get to use artificial intelligence model to get some functional parameter for this case perfusion. One of the good application is the image restoration. Actually, the image restoration process using the deep learning model shows very good performance. So when we use the deep learning model, we can reduce the dose more than 2 or 3 times, and it can successfully restore the conventional images. And furthermore, deep learning models shows very good performance for the segmentation tasks in the computer vision. So this kind of process is fully automatic, so they provide very reproducible myocardial segmentation. So we can get very accurate and reproducible volume parameters such as ejection fraction or end diastolic volume or end systolic volume. And another good application of the deep learning model is the generative model. Actually, one of the most commonly used generative model is generative adversarial network GAN, and it shows very realistic images using the random variable, or sometimes it can apply to the image-to-image translation. For example, we can get very realistic images using the sketch data. So this kind of generative adversarial network can be used to develop some multimodal imaging data. And one of the issues in the myocardial SPECT is the attenuation correction related artifact. Actually, SPECT CT can overcome some attenuation related artifact. However, many SPECT camera do not have the CT images. However, when you apply this kind of generative model, then we can get pseudo attenuation correction map. And using this map, without the CT images, we can get some attenuation map, and we can acquire the attenuation corrected cardiac images. So this can be very useful for the myocardial perfusion images. And this kind of images can be used to the quantification. This is not cardiac images, but we can get some anatomical images from the nuclear medicine imaging. This is a case of the fluorobeta peer PET, which is amyloid PET. And when we want to get some quantitative value of the amyloid quantification, we should segment the gray matter. However, using the fluorobeta peer PET itself, we can not identify the gray matter. However, when you generate the MRI using the PET, using the generative adversarial network, then we can get some gray matter segmentation more reliably. So we successfully get some MR-less quantification and only PET-only quantification using this generative adversarial network. So the image generation provides some new opportunity for the segmentation, accurate segmentation, and attenuation correction. And sometimes it can provide some new novel reconstruction algorithm for the better image quality. Now, lastly, I want to I want to emphasize the role of the unsupervised learning in the nuclear medicine imaging. Actually, for the functional imaging, we should focus on the data distribution instead of the simple diagnosis. Actually, this is a limitation of the supervised learning. When we train some model that classify the coronary artery disease and normal, then we usually use the specialized data set which have coronary artery disorder patients and normal. However, in the real data in the hospital, actually the normal control is more than the coronary artery disorders. And even more, patients are not came with the differential diagnosis of coronary artery disease and normal. There are many related disorders who have the chief complaint of chest pain. So this model for the differentiating CAD and normal cannot apply to this model, including another disorders. And another problem is when you change the application for the real data at community, this model cannot be applied to this kind of the situation. So we should focus on the data distribution. And a kind of the generative model can predict the distribution of the data directly. This is a model, deep learning model based on the variation autoencoder, and it can generate some pseudo images according to the aging. So this is a brain study. However, we can predict some aging data according the pseudo PET data according to the aging using the variation autoencoder. And this model can apply to the age-based data distribution according using this kind of generative model. And this model can be applied to get some to identify some abnormality using the normal data only. This is another example of the application of the model that identify the abnormality from the normal data. As you can see in here, this model just trained by the normal data, but we successfully identify some abnormality in here related to epilepsy patients. And this model also applied to the neurodegenerative disorders, and it shows abnormality in the Alzheimer's disease. So when we train the model using the normal data, then we can identify the out of the distribution. So this kind of model can provide some biomarker related to abnormality. So this concept can be applied to the myocardial perfusion imaging or other kinds of the functional cardiology images to get some abnormality as a biomarker. So in summary, functional biomarker is more important than the simple classification. And using the myocardial perfusion images, we can get some direct biomarker reflecting the prognosis or disease status. And actually, many kinds of the deep learning model application is related to segmentation or image restoration. And this kind of deep learning model can apply to get some accurate and reproducible conventional biomarker. And actually, unsupervised learning model can define the data distribution, and we can get some distribution-related biomarkers such as the abnormality biomarker. And this kind of approach can provide some new opportunity to be generalized model, which include a lot of multiple disorders. So it is important to identify the purpose of the artificial intelligence model in the nuclear cardiology. Actually, the purpose of the nuclear cardiology is not a simple diagnostic classification, but the purpose of the nuclear cardiology is to provide some functional parameters that can affect some clinical management plan. So future deep learning models should integrate multifunctional data to identify the spectrum of the disease to support the plan for the therapy.
Thank you very much for your nice presentation, Dr. Choi. Can you hear me?
Yes.
Yeah. So once again, I deeply appreciate your nice work and presentation. Okay. I have one question. So how about AI application in PET, cardiac PET? So nowadays, oncology PET is totally different compared with the cardiac PET. So moreover, at least in my experience, the instance of cardiac PET, the number of cardiac PET is still increase due in the evaluation, especially cardiomyopathy. So how about experience or knowledge about cardiac PET in the application of AI technology?
Yeah, actually, we attempt to apply some of AI model for evaluation of the cardiomyopathy using the FDG PET. Maybe you mean that FDG PET for the cardiac evaluation. And one of the key is to acquire some quantitative parameter of the inflammation or some metabolic function of the myocardium. And this should be combined with some anatomical information, because we should define some myocardium using the PET. However, it is very limited. So we can use some myocardial segmentation using PET-CT data or some generative model to get some accurate quantitative value of the cardiac myocardium metabolism. I think this is a good example of the application of the AI model for the cardiomyopathy using FDG PET.
So it is my own suggestion to you. So for example, in patients with sarcoidosis or hypertrophic cardiomyopathy, in the case MR PET fusion image or MR PET direct image will be is very useful. So this kind of fusion or integrated imaging will be helpful. Moreover, if you apply a technology, this kind of disease, maybe some good result will be expected. So it is only suggestion to you. Okay.
Yeah. Thank you for your suggestion. I think I agree. I agree with your opinion. And however, there is some difficulty in to get some PET-MR images on HCMP or other types of the cardiomyopathy patients because of some technical issues. But I think it will be very good to apply some AI model to evaluate some cardiomyopathy using the PET-MRI.
Okay, thank you very much once again. Due to time limitation, I should close this session. Once again, I'd like to thanks to all speaker and audience, so as well as Professor Bung Da Lu. Okay, thank you.
Thank you very much, and bye-bye.
Thank you very much.
Bye.
To the dreamers who imagine the impossible, who inspire the world with their ideas, and strive to provide clear answers for early and accurate diagnosis, for better outcomes, for better health, for every patient. Bayer wants to join you and make this dream come true.
My journey continues, and I know I'm not alone. Because together we can make a difference every day.